Ladies and gentlemen, I have the singular honor of inviting to the podium Pharm Aboagye Nyame, the thematic speaker for today. He is director of the $209 million Medicines Technologies and Pharmaceutical Services Program, MTAPS, a $6.5 USAID funded contract for strengthening pharmaceutical systems in low and middle income countries, LMICS, implemented by a consortium of partners led by Management Sciences for Health, MSH. In this role, he provides strategic vision and leadership and collaborates closely with USAID, country governments, implementing agencies, and partners on pharmaceutical systems strengthening activities to meet the goals of the program. He is also a member of the leadership team of MSH. Kofi Nyame is also the chair of the People That Deliver, PTD, a global initiative that aims to create a competent, supported, and adequately staffed supply chain workforce that is deployed across the public and private sectors within the health system. The initiative convenes its 40 coalition members and partners, all of whom have the same ambition to improve health outcomes, coordinates its network of member organizations by providing technical leadership and encouraging collaboration, and advocates for interventions that improve the demand and supply of qualified health supply chain professionals. Previously, Kofi Nyame was the program director of the USAID-funded Systems for Improved Access to Pharmaceuticals and Services, SIAPS, program, and guided the pharmaceutical systems, technical and managerial staff worldwide. A thought leader on pharmaceutical management with over 25 years of experience. He has specialized health and pharmaceutical and supply chain, particular quality assurance, pharmaceutical financing, capacity building, leadership and management positions on the strengthening pharmaceutical systems SPS $1 SPS program. During his time with SCMS, he provided support and oversaw project implementation in Botswana, Ethiopia, Namibia, and Tanzania. On the RPM Plus program, he served as the project lead on Namibia's pharmaceutical sector strengthening project under the President's Emergency Plan for AIDS Relief. Mr. Aboagye Nyame has direct knowledge of country challenges. Prior to joining MSH, he spent over 10 years with Ghana's Ministry of Health, serving as a deputy program manager of the Ghana National Drugs Program that sought to promote rational drug use, strengthen quality assurance of pharmaceuticals and pharmaceutical systems, improve the financing of drugs, and improve systems for procurement, storage, and distribution of drugs. And as head of the MOH procurement unit, where he oversaw the institutionalization of the ministry's procurement and was responsible for managing the procurement of goods, works, and services for the Ghana Ministry of Health. Mr. Aboagye Nyame is a pharmacist who holds an MSc in pharmaceutical analysis and
Thank you very much. Unfortunately, those dollars are not in my bank account. I would have gladly shared. Honorable Chair, permit me to stand on the earlier acknowledgements and to say all protocols observed. I think it's made my life very, very easy. It is indeed with great honor and enthusiasm that I stand before you today to deliver this thematic address at our 2024 Annual General Meeting and Scientific Conference. I would like to express my sincere gratitude to the Ghana College of Pharmacists for this opportunity to share my thoughts on the crucial topic of the role of specialist pharmacy services in achieving UHC and advancing towards the sustainable development goals. I also want to express my gratitude to the numerous folks that have reached out for data, opinion, and insights as I developed this presentation. I would also want to acknowledge the support provided by the USAID-funded MTAPS project that I manage for sponsoring my trip to Ghana and for participating in this AGM. The MTAPS program works to strengthen pharmaceutical systems in low and middle income countries. We currently are working in 19 countries. 6 of them are close. We are scheduled to end the project in March of next year. We work in 5 main domains: pharmaceutical policy, capacity building, human resources, both individual and institutional capacity building, regulatory system strengthening, pharmaceutical information systems, and also financing for pharmaceutical systems, and a cash-off program where we look at the supply chain and medicines used to ensure that patient outcomes are attained. Now, I put this picture here to depict the work that we do. A lot of the times, countries' health systems are burdened with a lot of problems, and that is depicted by the charcoal bags. Most of the time, we come in and we put in these pools to support it. But for as long as we are supporting it with pools, the track is not moving. We want the track to move. So what we do is to try to help countries, not with prodding them with pools, but putting the effort to remove those bags. We also want to encourage countries themselves to start removing those bags so that at the end of the day, we will be able to move the health systems forward and not them have to stay where they are. I've been working in this field for so long, but sometimes you go back to countries that you've worked in and you see the same problems coming up all and again. And if you look at the numbers of monies that we mentioned, it becomes sometimes very disheartening. The theme of this conference, Specialist Pharmacy Service for the attainment of UHC towards the SDGs, is not only timely, but also critical in the context of our national global health aspirations. As we all know, UHC aims to ensure that all people have access to quality health services without suffering financial hardship. And that is very, very important. We all know what our finances are, but you don't want the pills that we take and the x-rays that we take and the injections that we take to actually push us more into poverty. So pharmacists, particularly specialist pharmacists, play a very pivotal role in this healthcare system in both the public and the private sectors. It is very important to focus not just on the public sector. A lot of the time, this work that we do, we just look at the public sector systems, but most of healthcare delivery is actually done through the private sector. If you look at Ghana, for example, how many of us actually live in the areas where you can get access to the public systems? And so we need to ensure that our tentacles reach into the private sector that can do all of these things. Our expertise is needed in these areas. And so we need to ensure that the training that we are getting will take us there. But before I proceed, I want to pause and acknowledge an important group of pharmacists who have shaped me in my career all these years. These guys were very kind enough not to bug me with an embarrassing and horrible traumatic experience on my first day on microbiology class, if you recall. It was Brachikoku's class, and he said I should brush my hair and put some microbes on an agar plate. I was so scared that I actually rubbed the agar in my hair. He was shocked and horrified. So were my classmates. But I had to go out and do that. But these, my friends, they didn't give up on me. They supported me through the POSO, the cytochrome P450, the chymographs, and the frogs, and everything else that we had to do in the 7:15 a.m. starts. So thank you, Amma, thank you, Joycelyn, and thank you all for supporting me throughout this process. The Ghana College of Pharmacists actually is a great place to be, and I want to congratulate you all for becoming members, for becoming fellows. Some of us got it easy. We got a letter. We didn't have to burn the night oil. And so we want to congratulate you for the work that we do and for the work that the college does, because to move us into the era where we are taking pharmacy to the next level, and pharmacy is actually contributing to these health goals, then yes, we need institutions like this to actually provide the training, provide the specialization that is required for all of us to move forward and contribute our quota for the growth of this country, and to ensure that the training we have received will translate into positive health outcomes for the folks that we deal with. So why are specialist pharmacists important? I always want to start my presentations from here. Let's talk about these 66 Gambian children who were thought to have died because they were given unsafe medicines. Also, there's 68 children in Uzbekistan who similarly died. The pharmaceutical system failed them. Why should these tragedies happen? Why should these unfortunate events happen before we realize that bad medicines are around? You and I know that every day bad medicines are around and bad information comes with it. And as a result of that, these incidents happen. Again, data tells us that nearly 500,000 people are estimated to be killed by counterfeit medicines in sub-Saharan Africa every year. Of these, 267,000 deaths are believed to be linked to falsified and substandard anti-malarial medicines. This is scary. A further 170,000 are linked to substandard antibiotics for severe pneumonia in children. What are we putting our population through? What are we doing? These incidents can be avoided if we strengthen our pharmacy systems. There's a lot more. 4.95 million deaths estimated to be associated with bacterial antimicrobial resistance. AMR is out there. It's going to be the biggest thing out there, but we are not paying enough attention to it. We need to wake up. We need to work on these issues, because that is why we are pharmacists. That is why we have received this specialist training. And so we need to proceed and apply this specialist training. I'll give you a second to examine these pictures and think for yourself. Pharmaceuticals, we all know, play a pivotal role in healthcare delivery. Ensuring that these are available, managed, and used appropriately will save lives and save the country billions of cedis. I actually wrote millions of dollars. My editor said, why are you saying dollars? Say cedis and change it to B so that the impact will be made. It is true. So the role that we play in ensuring rational use, in ensuring the proper supply chain, in ensuring medicines do not expire are key. Where there are frequent stockouts, where the medicines are expensive, where the information is not available, people will react differently. I took this picture in Mali, and I'm sure you can find them around here. Go into the market and they are selling anything and everything, whether it is branded, whether it is in the regulated market or the unregulated market. We see these things around us, and it is happening. We really want to see pharmacies like this. This is my store. You can look at it. I closed it because I couldn't manage it. But it is important that as pharmacists, we put in place and manage the regulatory systems, the management systems that will allow us to do this. We need proper systems for patient counseling. That will allow us to do this. That will come. So let's come back to where we are here now. UHC and SDGs. We like talking a lot of acronyms. In the pursuit of UHC, specialist pharmacy services are indispensable, and I repeat that. In the pursuit of universal health coverage, specialist pharmacy services are indispensable. They ensure that our patients will receive the right medication at the right dose, at the right time, and for the right duration. This not only optimizes the therapeutic outcomes, but also minimizes the risks of adverse events, the risks of drug interactions, drug-drug interactions, drug-disease interactions. Specialist pharmacies also contribute to cost-effective healthcare by promoting the use of generic medicines and ensuring appropriate utilization of resources. The SDGs, with a focus on health and well-being, recognize the importance of access to quality health care for all. Specialist pharmacy services directly contribute to SDG 3, which aims to ensure healthy lives and promote well-being for all at all ages. They also indirectly contribute to other SDGs such as SDG 1, no poverty, SDG 2, zero hunger, SDG 10, reduce inequalities, by improving health outcomes and reducing the financial burden of medical products used to deliver health care in this country. According to the United Nations Department of Economic and Social Affairs Statistics Division, there has been some progress on improving global health in recent years. I take that with a little bit of a pinch of salt, but we would accept it that there has been some progress because the needle has moved. If it is not moved significantly, at least there has been some progress. They tell us that about 146 out of 200 countries have already met or are on track to meet the SDG target on under-5 mortality. Effective HIV treatment has been cut, related births by 52% since 2010. However, there's been insufficient progress made in other areas, such as reducing maternal mortality and expanding universal health coverage. Globally, we think approximately 800 women died every day. 800 women died every day from pregnancy or childbirth in 2020. And 381 million people were pushed or further pushed into extreme poverty in 2019 due to out-of-pocket payments for health. COVID-19 did not help, and the ongoing crises have impeded progress towards Goal 3. Childhood vaccinations have experienced the largest decline in 3 decades, and tuberculosis and malaria deaths have increased compared to pre-pandemic levels. Indeed, the world runs the real risk of not attaining these noble gains by 2020 as planned. Now, as noted by the UN Secretary General, unless we act now, the 2030 agenda will become an epitaph for a world that might have been. This is for all of us. We all have a role to play. So therein lies the importance of specialist pharmacy service. As pharmacists, we are uniquely positioned to contribute to this goal through our expertise in medication management, patient care, and public health. Ghana, like many other countries, strives to create a healthcare landscape where everyone has access to the quality care they deserve. The path to UHC demands innovation, efficiency, and a focus on targeted interventions. This is where specialist pharmacists come in, moving beyond the dispensing counter and logistics through the power of specialization. For far too long, the perception of pharmacists has been limited to dispensing medications and in managing drug logistics in the medical store. I recall my days at Kolegu, 1-3 times a day, 1-3 times a day, 1-4 times a day. We are gone past that. We are no longer the custodian of drugs. However, specialization unlocks a new era of pharmaceutical care, With the in-depth knowledge in areas like oncology, cardiology, etc., that we heard all of you have attained, you can optimize medication management by ensuring that our patients do what they have to do, get what they have to get, provide the information to prescribers and other dispensers. We're going to bridge the information gap by empowering patients through medication education, promoting adherence and self-care. We reduce hospital readmissions by proactively managing chronic conditions. We'll talk a little bit more about that later. I'm told Ghana has made some progress in achieving universal health coverage by 2030. However, with only 6 years remaining and our coverage index standing around 50%, there are indeed significant hurdles ahead for us to surmount. At the 2023 annual review meeting, the Eastern Region Health Directorate, some of these key health indicators like hospital admission rates, antenatal care visits, malaria testing, family planning, and breastfeeding rates have shown some improvement. So we need to really congratulate ourselves that we are doing a good job in this area. We need to make more efforts to expand coverage and improve access to essential health services under the National Health Insurance Scheme, which currently has an active coverage that we really are not happy with. So we need to help. I'm told that the Community Pharmacists Association has a plan to increase the number of pharmacies providing services under the NHIA to patients from 140 to 1,000. We'll be monitoring that. 140 pharmacies is really, really small. I can understand why, but we need to do our best to increase it to that 1,000 as a target. This indeed is a major contribution. Ghana has developed a UHC roadmap, and we've aligned our strategies and interventions to achieve this. So yes, we are on the path to doing this. So let's talk about the pharmaceutical system in Ghana. Indeed, the Ghana system is largely seen as very good compared to a lot of low and middle income countries. My work takes me to a lot of African countries. And when I see what they are doing now, that we did several years ago, it does give credence to the fact that we are ahead. Our brothers and sisters from Ethiopia are always coming to Ghana to come and learn from us. A lot of people come here and want to see what we've done and how we are doing it. When they hear that we are from Ghana, everybody wants to interview you. So we've done a good job. So we need to build on that. Our system encompasses a lot of agencies, including regulatory bodies, educational institutions, public and private healthcare facilities, community pharmacies, over-the-counter medicine sellers. I don't think I had all the logos in here. But this we are working. Now, successive public sector reforms has introduced some of these things, changed some of them, changed the mandates of these. But we've done a great job. We have a good FDA, we have a good pharmacy council, we have the Ghana Standards Authority, we have HEFRA, etc. And these entities have been hailed. For example, Ghana FDA is one of 4. I think we just had Zimbabwe join the level 3 a couple of weeks ago. But Ghana attained level 3 I think they will get there. So we've done a great job. Open issues that we need to take care of. All the required standard operating procedures. We do a great job with that. We have a national medicines policy that has been promulgated and works. And I recall during my days in GNDP, we used to print these things and go around and train a lot of people. So we started a long time ago. However, we need to look at what needs to be done to ensure that all these agencies play well in the sandbox. I talked to a lot of people before getting here. And according to one respondent, and I quote, "Strong governance and leadership structures are in place to oversee pharmacy services and make informed decisions. There is, however, a lot more to be done in the use of these structures for effective supervision. Key among them is commitment and consistency on the part of leadership," unquote. Again, another respondent said, and I quote, "Early MOH reforms and creation of the Ghana National Drugs Program was one of the best things that happened to the pharmaceutical sector. However, we lost the plots on governance," unquote. These views reflect the fact that there are structures in place. However, more effort is needed to fully realize the potential of the reforms and why the reforms were done. Fun fact, yes, I was indeed very excited when I heard that GNDP was one of the best things that happened to Ghana. Why? Because I was there. I was the first deputy program director with Divine for GNDP. So when I come back after 25 years and I'm told that the institution that you built is still working, I can be proud. So clearly, the regulatory and governance environment seems to have been set and is in place. So it's important that we use these to get to where we want to go. From the responses that I gathered, the most notable ones that are not really working for us is an apparent duplication of functions, ineffective collaboration and coordination, and information dissemination. The following quote from a respondent sums it all, and I quote, "Following the public sector reforms, several institutions and agencies have been mandated to play roles in the delivery and management of various aspects of pharmaceutical services in Ghana. The creation of these agencies by various legislations with different mandates and relate with a common cause and vision. There is sometimes duplication of roles and responsibilities among the agencies, such as between the pharmacy unit at the MOH and the Ghana Health Service, Pharmacy Council and HEFRA, Ghana Standards Authority and the Food and Drugs Authority, the universities and the Ghana College. This serves as a potential source of misunderstanding and conflict. Thus, there is weak coordination of the organizational structure for pharmaceutical service in both the public and private sectors in Ghana," unquote. Another respondent noted, quote, "Some work well together, but I think most of them do the same thing, leading to some rivalry," unquote. It was, however, noted that there was very, very good collaboration between FDA and GRA, and an MOU existed between the Pharmacy Council and HEFRA. Quote, "Collaboration between GSA and FDA has been great, with fantastic results on patient safety and strategies for public health impact. Not sure the same can be said about PC, MOH Pharmacy Unit, NHIA, among others. In terms of SDG development, excellent collaboration between pharmacists on WHO, NHIA, FDA, and MOH has been great," unquote. This leaves one to wonder if the current cordial relationships that we see among some institutions are structural and institutional, or based on the interpersonal relationships of the incumbents. For the avoidance of doubts and potential future disruptions, it is recommended that a comprehensive review of the boundary issues be conducted and the appropriate legislative and/or regulatory measures enacted to remove any ambiguities and inconsistencies and clarify overlap and responsibility structures in the pharmaceutical sector. How about education and training? If your school is not here, don't blame me. Several universities in Ghana offer pharmacy programs producing qualified pharmacists. And I'm told that a lot of folks from West Africa actually want to study in Ghana, which is a good thing because we are doing a great job. In addition, there are several institutions that have been accredited by the Pharmacy Council to train technicians and medicines counter assistants to build on the workforce needed. And of course, our college and the West African Producer College also offer opportunities for specialist training. Membership and fellowship programs offered by these colleges has led to graduates who have been certified and recognized as specialists, senior specialists, and consultants with improved remuneration in the health system. What is needed now is to use the competencies acquired to impact practice, policies, societies, and health outcomes. Because we are talking about specialist pharmacy services, and we are talking about you who have received the training. So what next? A respondent noted that, and I quote, "What is not good is that people go through all these programs, and unfortunately, in some instances, there is nothing to show regarding benefits or impact to the system, society, etc. Some just acquire certificates, titles, etc., and do not put into practice at all," unquote. Is this familiar to somebody? We need to change this perception or reality and remove the obstacles that mitigate against being able to apply the new knowledge. For example, and I quote, "In some instances, appropriate practice, and that becomes a disinfective," and unquote. I recall a personal experience when I returned back to Kolebu after obtaining a master's in pharmaceutical analysis and quality control from the UK, thinking that now I had a master's and so I can do more. The position, the degree was not recognized, the position was not recognized, and I had to go back and do what I used to do. So where is the incentive to spend the time and the money to train? So we don't even have the opportunity to apply the knowledge that we gain. So how can specialist services work if that's going to be the situation? We need to change that. We need to find a way to make sure that as we are impacting on UHC and SDG by studying, by training, there is a way to do it. I know that a lot of things, a lot of change has happened, and now there are specialists, and now there are consultants. But I think that's, we need to do more and ensure that more and more is done. Pharmaceutical care services provided by pharmacists and other cadres is offered both in the public and the private sector. And this comprises of all the hospitals, the polyclinics, the teaching hospitals, and we play a major role in ensuring that these things get done. Let's not forget the major contribution from the private sector, the community pharmacies of the urban and the rural communities in Ghana. It is important that we recognize all the contributions from all these cadres. The main issue that has been noted with service delivery outlets, however, is that of compliance. Whether it was the community pharmacies complying with the legal provisions of a pharmacist oversight, or OTCMSs stocking and selling medicines that they are not expected to carry. One wonders where they bought them from. The causes of this situation are myriad, and we cannot delve into them in this presentation. However, it is important to note that the regulator does not have the adequate resources now and will not have the resources in the future, near future, to inspect and police our facilities to ensure compliance. So there is a need to rethink the approach to enforcement. That has been the biggest problem. One of the issues that my project was supposed to look at in regulation was enforcement. Trust me, We've not found a way to do that. However, I have a belief that a reliance on inspectors from the council will not solve the problem in the near to mid-time. I believe we cannot rely on inspection anymore. Inspection is a point, then I come today, maybe you know I'm coming, after that I go, and I may not come back for a year or two. It is like we cannot inspect compliance into pharmacies and OTCMSs. We need to devise new models for supervision. That may include incentives for self-monitoring and compliance, involvement of the community, local government and traditional authorities, and technology. In parallel with the routine spot inspection that is currently practiced, we need to do that. I recall we did some work in Togo where we were supposed to collect data on HIV/AIDS dispensing in the hospitals. The nurses who were managing these facilities could not do it because of workload or because of other things. So we approached the people living with HIV/AIDS community, and lo and behold, they were ready to do all of that. Every day they will send 2 people into the hospital and they will capture all the data that we need. So we can think through it. I don't have the solution. There are too many outlets to have a cost-effective inspection program. Kenya has over 45,000 outlets. We'll talk about the Ghana's situation pretty soon. How can you inspect all these outlets routinely? So let's think more. Another area of concern is the circulation of falsified and substandard medicines. Despite all the regulatory efforts, it's still there. Ghana, we are blessed, actually. Ours is much lower. You should go next door to the Francophone countries, and it's terrible. Men will tell you. The disparities and limited access to pharmacists, limited access to pharmacists in both areas is something we need to talk about. The real question is that, can we have a pharmacist in every place? No. So how do we become creative to ensure that the pharmacist service can reach those other areas where a pharmacist cannot be present? I believe that we can be creative. I took some statistics from the Ghana Pharmacy Council yesterday. We have a total of 6,400 registered pharmacists. And boy, only 5,000 are in good standing. You are making my brother's job difficult. Go and pay. We have 5,600 registered pharmacies. We have 25,000, almost 26,000 OTCMSs, 14,000 in good standing. How do you inspect 26 plus 6 in our environment, in our small country? So we all, as pharmacists, as public health people, as specialists, need to find a way to support this. We have good training institutions that is going there. But I looked at this data from WHO and I was not really happy. This is number of pharmacists per 10,000 population. And across the years, they are all below 0.5. So we need to do more work in making sure that we have enough pharmacists to serve our populations. Our regional distribution doesn't look good. So all of us are sitting in Accra. This is no news. But we need to help the regulator to send the services there. So now that we have specialist pharmacists, how are we going to do that? So let's come back to why we are here, the role. So we've discussed the current policy. We've discussed the situation we have in our pharmacy services. So what role do you have as a specialist now? How are you going to change the landscape so that we would attain our UHC and we attain our SDGs? With the help of my good friend Gemini and ChatGPT, I managed to come up with a few things. One, we need to ensure access to and appropriate use of essential medicines and services. And I really want to note here, that what we are calling specialist pharmacy services are probably not so new. They are the same services that we have been providing over the years. However, we are placing more emphasis on it now by providing focused and specialized training that is certified. Because all of us were doing medication management, or we are expected to do medication management. All of us were supposed to ensure access to essential medicines. But now we are tasking you because you have been given a certificate, you swore an oath, and you've been trained. So we want to see an upward apologize. But as specialists, our role in the development of effective medication management protocols cannot be overstated. We need to reduce medication errors. Now there's data, now there's technology. How are we working with our prescribers, with the other healthcare workers, to ensure that we are part of the management of the patient and the management of the community? We need to provide that information because, as SDG 3 says, good health and well-being, it's our role in there to ensure proper access. We also need to enhance pharmaceutical care and clinical pharmacy. I mean, I think clinical pharmacy we've talked a lot about. Now all our schools are providing clinical pharmacists. I remember a long time ago when we started training clinical pharmacists here, there was a huge battle as to why do you need to train all these clinical pharmacists, and it has, and I'm glad that we did not back down, we did that. So we need to do all this. It is important. We need to work in combating antimicrobial resistance. I mean, AMR is a big issue. And it's not just in the human sector. We are eating and consuming antibiotics that are coming from our chicken, that are coming from our goats, that are coming from our fish. I was in a hospital in DRC, a children's hospital, and their records in the hospital show that if you dare give any baby a first-line antibiotic, you are killing the baby. Because the mothers are consuming a lot of antibiotics from the fish from the river, that by the time the babies come there, they are always resistant to anything and everything. So can you imagine the costs of starting to treat these babies with those higher level antibiotics? AMR is a big issue. As specialist pharmacists, we can play a role. Now, AMRs, the problem with AMR and solving it is not always about prescribing. There's a lot of misuse. There's a lot of information. There's a lot of pushing medicines that are making the chicken fat. We need to talk about these things. Our efforts in preserving antibiotics are crucial because there are no new antibiotics in the pipeline. There are no new antibiotics in the pipeline. We don't want to go to the days before Fleming, the days before penicillin, because it can happen. Antimalarials. Those of us who use chloroquine, it was easy and cheap. Bitter though, yeah, but it was easy and cheap. Now we are using ACTs and they are telling us to do RDTs before ACTs, and they are becoming very expensive and we don't do it, even though we are supposed to. What else? We've seen that artemisinin resistance is developing. What is our role? We need to do that. We need to adopt the multi-sectoral collaborative approach. So wherever you are, public sector, private sector, work with your community. We need to promote health and wellness. Preventive health measures are where we need to be going. If we don't look at those things, we would have a problem. We need to address equity. We need to strengthen health systems. And we need to foster collaboration through research and education. We need these areas. I wanted to talk about specialist areas, but I wouldn't, because I noticed that all of you are either clinical pharmacists, oncology pharmacists, or geriatric pharmacists, or regulatory pharmacists, or supply chain or procurement pharmacists. So let's leave that. I didn't hear mental health pharmacists, though. Only one. You need to do more. I didn't hear compounding pharmacists. When I started with JOT, that was what I was doing. I didn't hear clinical trials. I didn't hear pharmacoeconomics and health economics. We need you. Health technology assessments. we need to start looking at some of these things. Okay, so let's move on. So what are some of the challenges and opportunities that we have in order to do this? Now, I just wanted to situate why we are doing this. Now, it's important to notice that specialist healthcare services, pharmacy services cannot happen in a vacuum. They must happen within the existing pharmaceutical system. And the pharmaceutical system, as we know it, is also part of the health system. In a paper that we published a few years ago, we tried to define what pharmaceutical systems are. And that is all the systems that encompasses it. So if you look at it, then everything along this chain here, we now call this the pharmaceutical system pathway or the snake, whatever you want to do it. But from clinical trial all the way to pharmacovigilance, you will need to have some specialist input. And so, yes, we can have specialists along all these things so that we'll be able to have a way of providing the services and the care that we need. We are saying that for a very long time, pharmacists have been seen as bringing products. Pharmacists have been seen as bringing products and medicines and tablets. We need to go beyond that and be seen as part of the environment that does the work that we do. Our nation can better harness the benefits of specialist pharmacy services if we work in the three most important areas of policy and legal framework: governance and management structures, and workforce issues. I've talked a little bit about the policy and regulatory framework when I talked about all the legal institutions that have been established. We have done a great job because we have all of them, but we need to find a way to remove the boundary issues so that they can work better together. We also need to ensure that we look at the governance structures that we have. And by governance structures, I'm thinking about who has the stewardship for pharmaceutical services within the country? Who is responsible for ensuring that the totality of pharmaceutical care is done and is monitored and is reported on? And if one agency is not meeting their targets and goals, they are called to order. Who has that? Is it Pharmacy Council? Is it Food and Drugs Authority? Is it the Ministry of Health? From my research, I really do not see that any one of these entities have that clear mandate. All of them have some aspects of it, but no one has been given that clear mandate to say, you are the one who is going to bail the cats, and you are the one who is going to do this. So I think that we will need to be working on that area. So we need to figure out a way to get into that space. I got involved in all this work about 30 years ago when I was doing my MBA, and the lecturers went on strike as usual. And Commodore Sibo Bimpe was the minister and the chief pharmacist of Mr. Fufi. And he called me and said, you are taking study leave with pay, you are not doing anything. So I ended up visiting almost every hospital and almost every dispensary with a pickup truck, with some friends, Morton, Divine, Johnny, to see how the cash and carry was doing. So that is how this started. That was the precursor or the predecessor to the Ghana National Drugs Program. The problems that we realized at that point, some are gone, but some still persist. My dad was a pharmacist, so I've been involved in pharmacy services in both the public and the private sector. Those days we used to do mixtures, if you remember. Washing those bottles and then going around. And so we've done some of that. So it means that we still have a role to play to do that. I put this case here, I'm skipping ahead, to show a case study that we did in my project to look at how are the governance systems being managed. Because we realize that for the most part, all our chief pharmacist offices, all our directorates of pharmacy go across Africa. They become logistics management units. And all they do is LMIS and procurement and storage and distribution. A focus on national medicines policy, policy implementation plan, policy evaluation, and making and taking care of that stewardship is a bit lost. And so we commissioned this study, and it was led by, we contracted Augustine Akodia, to help us to do that. And yes, it was confirmed that there's the focus on supply chain because the donors and technical assistance agencies like myself, we come in and we are focusing on HIV, malaria, and TB. We are not really focusing on everything else, the ARIs and all of that. And so we pushed everybody in that thing. We found that institutional capacity for other administrative things in pharmacy was missing, and that there was no blueprint as to how a pharmacy department must work. And so we have proposed some mandates, and I'll go into that very soon as to how we think we should be managing our pharmacy systems. But before I do that, I want to draw your attention that today we are looking at pharmacy from the institutional perspective. Patients come to the hospital, they go to the dispensary with a prescription and they get their medicines. Patients come to your shop or your pharmacy and they ask you for something or give you a prescription. The youth of today think differently. Now we have Uber, we have Grubhub, we have Yango. We are ordering our food in our rooms and our food is being brought to us. Very soon, in the next few years, we'll be ordering all our medications, and thanks to the Pharmacy Council, we now have the NEPP. NEPP, right? I think right. So we have the basis of utilization of technology. But we need to look at how are we using our specialist pharmacy services to be ready for the pharmacy of the future. There's a study that is being done, the report is about to be published, and we're talking about the supply chains and the pharmacy systems for 2040. Are we ready for 2040? We may think that it is something else, but if you recall, Y2K, those of you who are old enough, you know what Y2K is. It came in and we thought it will happen and it didn't happen and it happened. You know about Polaroid. You know about Kodak. If we are not careful, we will be here and things will overtake us. The pharmacy systems of the future are not the pharmacy systems that we are having now. Our children think differently. We need to examine the needs of the patient. We need to examine why people are going to certain places to obtain their healthcare services. And we need to be responsive to that. I can posit that in a few years' time, 20, 30 years, we will not need any OPD pharmacies within any of our hospitals. We will have to be working with our community pharmacies, with our patients. We need to provide our services closer to our patients. Because I live in America. I don't go to any pharmacy to collect my medicines. It is always mailed to me. We are getting there. We think that the pharmacist is the one who should always provide that and carry the products to us. It's changing. So we need to look at the legislation that will allow us to be able to respond to the needs of the future. Now we are talking about, here we sit here, we are looking at access issues. We have laws on the books that prevents certain cadres of pharmacy workers to give certain medicines out. And yet we want to reduce maternal mortality when most of it is happening in the rural areas. But the OTCMS cannot dispense certain things. There's demographic transition happening. There's epidemiological transition happening. We have a lot of hypertension in the villages, but the OTCMSs cannot dispense those things. Come to specialist pharmacy services. There are laws that will prevent you from providing some of the specialist pharmacy services because those may be in the realm of other cadres or staff. We need to be looking at how to remove some of those boundaries so that we can get these things to work. So yes, patient-centered services are going to be very critical. Understanding where the patients and why the patient needs what they have. Climate change is here. It will impact us. There's migration. There's a lot of things happening. Our youth think differently. And we may think that it's not important, but the way they are demanding other services, it will translate to the way they demand healthcare very, very soon. Emergency services. So we need to look at that. We need to invest in capacity building as we are doing now. Otherwise, we cannot make it. So, let me quickly go through this. So I won't go through that. I'll just go to Ghana meets the recommended guidance in a lot of ways. We had proposed that you need to have a medicines regulatory standalone, like the FDA that we have. You need to have the pharmacy services unit within like the Ministry of Health or the Ghana Health Service or teaching hospital. It doesn't need to be standalone, but it must be high level enough to interact with the authorities. You need to have a supply chain management unit. Same way, it doesn't have to be standalone. But there are a few people who are challenging this model now. Do we really need a supply chain management system within the public sector, or we need to be collaborating more and more with the private sector, not just for warehousing and transport, but also for the actual dispensing of those commodities within that? South Africa has done it, Kenya has done it. There's a lot of down referrals that we can use. We need to have a pharmacy practice like we have in Pharmacy Council, but the overarching recommendation that we made, which in a way for me is not necessarily in line with what we have in Ghana, is having a unit whose primary mandate is to act as the steward of the pharmaceutical system. So if there's any issue about the pharmacy system that is implemented by the Pharmacy Council, the FDA, Standards Authority, HEFRA, what have you, there is one place that is monitoring all of this. The data is there and they can inform everybody about it. We need to have that unit. We propose that that unit should report directly to the ministry, but for in Ghana, we have a different system. Our ministry has a technical directorate, so the director reports within the technical directorate and it goes to the ministry. But I'm not too sure that the actual mandate as written now covers the totality of the stewardship. So we may need to take another look at that and see how best we can get that. This paper is yet to be published. I have to sign off on it so that it can come out and then you can have a look at it. So this is what our unit in the Ghana Ministry of Health looks like now. I like the way it is set up, the policy, regulatory data, and then M&E. You can see how best we can utilize this to oversee pharmaceutical services, not only in the public sector, but in the country. So whether the services is delivered in the private sector or the public sector, like Pharmacy Council has mandates across, we need to ensure that that oversight is provided and the data is managed so that we can track what is happening and what needs to be done. To conclude, I brought back this slide that I discussed in 2017 when I was the thematic speaker at the AGM, the Pharmaceutical Society AGM. There, I proposed that we should be moving the pharmacist from being the custodian of drugs to the manager of pharmaceutical care. How do we regulate that? How do we ensure that the OTCMS in that rural area can benefit from the pharmaceutical services oversight from the next door pharmacist? There's a lot of technology. There's telepharmacy. There is all those things that we can use that we can provide that. Majority of our population will not benefit from your specialist services because of the way we are structured. So what should we do as a college? What should we do as a profession, as a ministry, as an agency to ensure that the benefits of specialist pharmacy would actually be felt within the population? We are training people. We are spending money. But some of the structures will not allow us to do that. We need to figure that out. We cannot be happy with the current system that we are doing it here for ourselves. When our mothers, our cousins within the rural areas, yes, they get medicines through these OTCMS, and some of them are getting from their head teacher's office, but they are not getting the pharmacy oversight. We would not get enough pharmacists to be able to do that. But we can collectively think about a way to be able to provide that oversight and that services. It is a challenge. I talked to a couple of guys about what should pharmacists do now? One of them said, tell the pharmacists to leave the supply chain. Tell the pharmacists to leave the central medical store. It's not going to solve the problem. I probably believe a little bit in that, because I believe that, as Jack said, the healthcare system has to find a way to disconnect pharmacists from the delivery of products and connect them to the delivery of services. That is our job. We have to grow and provide those specialized services. As I indicated, those specialized services are core pharmaceutical services. We have enhanced them. We have gotten a certificate about them. We are happy about them. But how do we make sure that the population actually benefits from it? We would need a system somewhere that will monitor the impact of the oncology pharmacist, the impact of the cardiology pharmacist, the impact of the supply chain pharmacists. Now we know the supply chain pharmacists. A lot of pharmacists are in procurement. I used to be there. So we see them, we see what they do. But how are we showing that the oncology pharmacist is actually making a difference? Where's the data? How are we showing that the respiratory infections pharmacist is making a difference? We need to start building that data system now if we are actually going to make an impact on UHC and the SDGs. So I'm leaving you with this slide, which says we must be dedicated, we must be disciplined, and we must differentiate. You've done it already. You've attained the fellowship, the membership. You've started the differentiation. You need to be disciplined by applying your knowledge. Do not go and hang your certificate and say, now I have a degree. Now I can write what were the letters that he said and add to your name, and then that is it. You need to be dedicated to the work. Ghana needs you, the country needs you. It's 6 years to SDG. We are nowhere near. But let's see what you as an individual with your qualification can do and make that difference. It is important that we do that. Then our contribution as specialist pharmacy would make a difference in the lives of ourselves and of our population. Thank you very much for the opportunity. God bless you.
Thank you very much. Thank you very much. Please, let's give it up.